The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria for The Genuine Article, and now I'm speaking with Leslie Shaw. Leslie is well known to almost everyone, and she's professor of medicine at Emory University and has been involved in a great number of areas in cardiology. Leslie, what we're talking about this morning is the article that you're about to publish in JACC dealing with ischemic heart disease in women. And I'm very interested to see that you prefer to call it ischemic heart disease rather than coronary artery disease.
Yes, it's an exciting time in women's health. We really are at a convergent point where we have dramatic new evidence. And I think the term ischemic heart disease more aptly reflects what is going on with our female patients. First of all, we know that women have less obstructive coronary disease. They have more angina. They have a lot of ischemia. And so therefore, if you think about talking about coronary disease in women, it doesn't seem to aptly fit as much as ischemic heart disease does, given the prevalence of angina and ischemia in female patients.
Sure. So there's this disconnect between angina and ischemia and obstructive coronary artery disease. Now, given that, is there a difference in the risk assessment for problems in women?
Well, intriguing enough, despite the fact that women don't have extensive and severe obstructive coronary disease to the same prevalence as men, they have a higher mortality risk, a higher cardiovascular event risk, largely. An abundance of recent evidence shows that even women with angina, nonspecific chest pain, have a higher incidence of incident infarction. And therefore, some of the more outside the box, if you will, ways to estimate risk in women are going to have to be brought into this equation for us to understand what's going on. For example, inflammation. We know that women have a higher levels of C-reactive protein that begins at the age of puberty. This novel risk factor is one which is going to be increasingly important in women. Sex hormones are increasingly important in understanding risk. We know that 10 to 15% of women have higher androgen states or polycystic ovary syndrome, have lower estrogen levels, all of which is going to affect their risk of cardiovascular disease, as well perhaps mediated through their risk of diabetes. So many of these novel risk factors are going to have to be included when we think about doing a good job at estimating risk in our female patients.
So we're dealing probably with microvascular dysfunction in women, but nevertheless, those women with normal coronary angiograms and angina that we used to think really didn't have disease or were benign really may be at risk. Now, what about therapy? How do we approach therapy in these women?
Well, this is where we come to the crux of where we need to go in future research. We do know that women who have vascular dysfunction, they perhaps have an underlying burden of non-obstructive atherosclerosis. So therefore, we can intuit that these women could be treated similar to patients with obstructive disease with anti-ischemic therapies in an attempt to ameliorate their symptom burden and their ischemic burden. So that we do know. But we don't have a lot of strong evidence. Anything that I would quote you right now would be purely based upon small series. However, that being said, beta blockers have been known to improve vascular dysfunction. ACE inhibitors and statins, there's a real strong body of evidence that both of those agents can be very effective at reducing symptoms and improving ischemia, reducing ischemia. And therefore, we think that if you think about these women with normal coronaries, perhaps non-obstructive atherosclerosis, evidence of vascular dysfunction, think about these three drugs in order to see if that will improve their symptom burden and their amount of ischemia.
Well, there really has been some increased understanding of the fact that ischemic heart disease in women is a bit different than it is in men and requires a bit of a different approach. This manuscript really points that out very well. Thanks for being with us.
Thanks, Tony. Glad to be here.
For The Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.